Okay. I think we can start. I invite Dr. Swan
Good evening, everyone.
Yes, I invite Dr. Swan for this session, and she'll be the moderator. She's a consultant pathologist at Apollo Hospitals in Hyderabad, and her areas of interest are gynae, GU, and neuro path, along with the medical renal pathology. Now, Dr. Swan, as chairperson, she will be introducing Dr. Jasreman. Over to you, ma'am.
Hello. Thank you, Dr. Bedi, for that lovely introduction. Am I audible?
Yes.
Yeah. So it's indeed a privilege for me to introduce to all of you Dr. Dhillon this evening. She's not a new name in this field, and for many of us, we've actually heard her speak in many of our meetings. Yet, for those who may not know her, Dr. Jasreman Dhillon is a senior member in the Department of Pathology at Moffitt Cancer Center and a professor at the University of Florida in Tampa. Dr. Dhillon is a section head of geopathology at Moffitt Cancer Center, and she did her medical schooling from Government Medical College in Chandigarh, which was followed by a residency at PGI Chandigarh. She then did her GU fellowship from MD Anderson Cancer Center, and she, of course, is an active academician, and all of us know that, with numerous papers to her credit. She is also the director of the fellowship program of a combined GU-GYN fellowship at Moffitt Cancer Center. So with this, I'd like to invite Dr. Dhillon to deliver her lecture on a fairly complex area, Cribriform lesions of the prostate gland. All over to you, Dr. Dhillon. You need to unmute. You're muted, Dr. Dhillon. Oh, you're muted again.
Can you hear me?
Yes, we can.
Okay.
Thank you.
Thank you very much for the kind introduction. So without delay, and thank you, Dr. Bedi and Dr. Swain and Dr. Lobo and the team for putting up these lectures in the memory of our very dear colleague, friend, and mentor, Dr. Mohanty. So I'll start with my lecture today. This is Cribriform lesions of the prostate gland. I shall, okay, so this is a few words about the normal histology of the prostate gland. It comprises, as all of us know, epithelial cells and the stromal cells. The epithelial cells are arranged in glands composed of ducts and acini. These ducts and acini are again composed of two types of epithelial cells. On the inside are the secretory cells, and each gland and duct is lined on the outside by...
Sorry, can I interrupt briefly? Could you please put it on slideshow?
It's okay.
Not on slideshow yet.
Can you see it?
Yes, thank you. Thank you. I'm sorry for that.
Okay, thank you for letting me know. And most of the benign prostate ducts and acini have corpora amylaceae within them. Now, to identify the presence of basal cells, we use immunohistochemical stains. These can be stains like P63, which is a nuclear marker, or a high molecular weight cytokeratin, which is a cytoplasmic marker. We can use them individually, or we can combine this into a cocktail called PIN4, which may not be available in all of the labs. If it's not available, then we can use these individually. So all benign glands should have a basal cell layer present around them. So how do we define a cribriform pattern? So cribriform pattern in prostate cancer was defined by the ISUP Consensus Conference. They defined it as a confluent sheet of contiguous malignant epithelial cells which have multiple glandular lumina, which are easily visible at low power at 10x. There should be no intervening stroma or mucins separating the individual or fused glandular structures. And there is no size requirement criteria present as well. We know the cribriform glands in different papers. Some say small cribriform glands, large cribriform glands, but and there are different criteria if we look at different studies, how they define a small or large cribriform glands. But however, there is no standardized criteria to differentiate the two. Now, here are some of the examples which are and which are not cribriform glands. If we see on the top left-hand corner, here the tumor cells are present in sheets of tumor cells. This is a Gleason pattern 5. This is solid focus. We would not call this cribriform pattern. Again, on the top right-hand corner, we see expansile growth, where you can see in the lumina with many of these have empty spaces within them. So in these kind of lesions, yes, cribriforming is present. However, I would also zoom in on high power to see if there are any rosettes, because if rosettes are present, then pattern 5 is present along with a cribriform pattern as well. If we come to the lower left-hand corner, again, this would not be called a cribriform pattern. Why? Because carcinoma cells are separated by capillaries here. So the carcinoma cells and cribriform lesions should not be separated by capillaries, by fibrotic stroma or fibrovascular stroma. On the right lower hand corner, again, it is not a cribriform pattern because carcinoma cells are separated by collagen or stroma in between them. Again, another example where the consensus was cribriform pattern is not present. So it shows a gland with 3 lumina. Some may feel it may represent fusion of the glands or maybe even tangential sectioning. So this was not equivalent to cribriform lesion as well. On the right-hand side, you see a small gland with a cribriform pattern present. You can see the smaller sheet of contiguous tumor cells with multiple punched out lumina in between, so which are easily recognized at low power. So yes, this is a cribriform pattern. Now, cribriform pattern is one of the 4 architectural patterns which comprise a Gleason pattern 4, the others being poorly formed glands, which you can see here in the top right-hand corner, fused glands, glomeruloid glands, and cribriform glands. Now, out of these 4 criteria, it is the cribriform glands which are associated with bad prognostic features like advanced stage and lymph node metastases in subsequent radical prostatectomies. Once we say cribriform glands are present in on a needle biopsy, the patient is ineligible for active surveillance. Why? Because again, these are associated with bad prognostic features like metastases in the lymph nodes and also advanced stage. So whenever you have cribriform lesion present on a biopsy in a prostate cancer, you have to report it.
Dr. Dhillon, sorry for
Yes.
interrupting. Can we have it on full screen? It's not yet on full screen. It's on slideshow, but not on full screen yet.
Hold on a second. Where did I go?
Sure.
Give me 1 second.
Sure.
Okay, do you see it on full screen now?
Not yet.
Oh, here. Do you see it on full screen?
Yep. Yeah. That's good. Thank you.
Thank you for letting me know. Okay, so now on the left-hand side, you can see there is dilated glands, and then it's got cribriforming lesion within it. However, it's attached on one side to the dilated gland and is not attached on the other side. Now, this is the glomeruloid pattern of prostate cancer. This is not to be called a cribriform pattern. This pattern has a relatively better prognosis compared to the cribriform pattern. Similarly, on the right-hand side, you see mucinous cancer. Here, the cells are separated by these mucin and collagen stroma. So this is again not to be called Cribriform pattern. This is mucinous carcinoma. Right. Okay, so now I will present case 1 of a 52-year-old man with an incidental finding on prostatectomy. So this is the lesion you can see at low power, pretty well circumscribed nodule, and you see these epithelial cells, and these epithelial cells are arranged in ducts and acini that are expanded by proliferation of the epithelium within them. And a little higher power, you can see there is a nice basal cell layer, which we can appreciate even on low power around all these glands. However, when you come see within these glands, they are expanded. There is epithelial proliferation. And by definition of the cribriform lesion, these epithelial proliferations are forming cribriform lesions with presence of well punched out glandular lumina in between them. And again, very high power view of one of the glands. You see a presence of basal cell layer all around it. It's proliferative. It is forming cribriform lesions. But one thing to note here is the epithelial cells are absolutely bland. There is no epithelial atypia. So this is clear cell cribriform hyperplasia, which is seen from time to time. This hyperplasia affects the transition zone of the prostate gland, and it can mimic the dense cribriform pattern of intraductal carcinoma of the prostate. However, it lacks a nuclear atypia. There is no comedonecrosis, and of course, a prominent basal cell layer is present around it. But that does not distinguish it from IDCP. It's the lack of nuclear atypia and absolutely bland morphology. So we'll move on to case 2, which is prostate biopsy in a 72-year-old man. Now, on the left-hand side, you can see the prostate biopsy. It is composed of this lesion, which is expanding the ducts and acini, and there is dense cribriform proliferation that is happening within these ducts and acini. Now, what do I mean by dense cribriform proliferation? Dense cribriform proliferation means the cribriform, the proliferating cells are occupying more than 50% of the luminal space in the duct or the acinus that is involved. And on the right-hand side, this is a pin 4 staining. You can see presence of basal cell layer around these proliferations. So this is intraductal carcinoma of the prostate. Now, WHO book defines intraductal carcinoma of the prostate as a neoplastic epithelial proliferation that involves the pre-existing ducts and acini, and it expands them, and it is characterized by either architectural and cytological atypia, which is beyond high-grade PIN. So this is a proliferation which is more than high-grade PIN in terms of architectural patterns, as well as cytological atypia. Now, intraductal carcinoma of the prostate was first defined by Covey et al. In 1985, and the term was coined by McNeil in 1996. However, it gained widespread recognition by the paper by Drs. Guo and Epstein in 2006, where they described the features of intraductal carcinoma of the prostate in prostate needle biopsies. So what are the features of intraductal carcinomas of the prostate? The glands that are involved are usually expanded. They can be irregular with branching contours, or they can be absolutely rounded and uniformly expanded. The second criteria is the architectural patterns to it. There can be dense cribriforming, the pattern we just saw. There can be a solid growth present within these expanded glands with retained basal cell layer. However, if you do not have dense cribriforming or solid growth pattern, but you have micropapillary or loose cribriforming, then you need presence of either comedonecrosis or marked nuclear pleomorphism or nucleomegaly to diagnose intraductal carcinoma of the prostate. And of course, if you do immunostains, basal cell layers will be present. And a few words about cytological atypia. The cytological atypia, you have to have marked nuclear pleomorphism within the epithelial cells forming the lesion. There has to be nucleomegaly. This was defined to be at least 6 times larger than normal cells by Guo and Epstein. However, in 2019, a GUPS paper on Gleason grading, they further clarified this nuclear size criteria and said that specific nuclear size criteria is not required. As far as there is marked variation in size and shape of the nuclei, which far exceeds that seen in high-grade PIN, it should be good to call it intraductal carcinoma of the prostate. And now, this microphotograph, you can see there is marked expansion of this duct or sinus, and there is proliferation of dense cribriforming within it. And on top of it, you can see again marked expansion of a duct with presence of comedonecrosis inside it. Now, if you do basal cell markers are preserved in the top gland, you see, very well seen. However, on the lower bottom size, the basal cell are present, but they are patchy in nature. So you can have either very well nicely demarcated basal cells, or even if you have patchy presence of basal cell markers, it still is intraductal carcinoma of the prostate. Now, if I have dense cribriforming or I have solid sheets, I do not need a severe cytologic atypia as long as nuclear atypia is present. Obviously, to call it intraductal, we need to have nuclear atypia as well as nuclear atypia, which can be similar or little more than high-grade PIN, as long as the architecture of dense cribriforming or solid pattern is present. If I do not have dense cribriforming or solid pattern, then I need to have severe nuclear atypia or comedonecrosis. Now, this pattern again is close to, here you see this is the solid pattern of the intraductal growth. And on the right-hand side, if you see the nuclear atypia, there is a nuclear atypia present as well. And if you do basal cell markers like P63 and high molecular weight cytokeratin, you can see presence of basal cell layers very nicely highlighted by these stains. However, if you do not have dense cribriforming or you do not have a solid architecture, as I said before, you need to have either comedonecrosis or severe marked pleomorphism with retention of basal cell layer to call it intraductal carcinoma of the prostate. Now here, the nuclear atypia is markedly more. It is more than what we see in high-grade PIN. And if you do the basal cell layer, it is retained around this gland. Hence, this would be classified as intraductal carcinoma of the prostate. Again, here, the most common architectural pattern that we see in intraductal is the cribriforming. Here, again, you see cribriform glands. And on the right-hand side, you have a basal cell layer marker, P63, that highlights the presence of basal cell layer. And as I mentioned before, the basal cell layer can be contiguously present or it can be fragmented as seen in this gland on the top. So there are classically two pathogenic pathways of intraductal carcinoma of the prostate. The more common is the retrograde spread of intraductal carcinoma of the prostate, where it's believed that the high-grade prostate cancer that is present, it starts growing within the pre-existing benign ducts and acini. And it represents an aggressive form of prostate cancer. The Gleason grade is high, it's usually 2 or above. There is high stage, high volume of prostate cancer, and it leads to, and is also associated with treatment failure and early biochemical relapse. And the genetic alterations seen in the retrograde spread of intraductal carcinoma are similar to that seen in more aggressive prostate cancers. There is loss of PTEN and upregulation of ERK. The second type of intraductal carcinoma of the prostate is the precursor lesion, also called in situ intraductal carcinoma of the prostate. These are exceedingly rare types of intraductal carcinoma of the prostate, and it can be pure intraductal carcinoma of the prostate without any associated prostate cancer, or we can have intraductal carcinoma of the prostate and the associated invasive cancer is only grade group 1. Now, these are exceedingly rare, as I said, and they are also associated with a mutation profile which is different from the regular type of intraductal. These are associated with MAPK and PI3K gene mutations involving these two genes, and they have better prognosis. Intraductal carcinoma of the prostate, when pure or associated with grade group 1, will behave like a grade group 1 prostate cancer with 5-year biochemical recurrence-free survival at 93%, which is equivalent to that seen in grade group 1 prostate cancer. However, when diagnosed on biopsies, you have to remember that majority of the cases will still be associated with unsampled prostate cancer grade group 2 or above. Only 10% of the cases of pure intraductal carcinoma of the prostate that are diagnosed on biopsies will show pure intraductal carcinoma of the prostate on prostatectomies, whereas 90% will be associated with unsampled high-grade prostate cancer. And only 20% of the cases that are diagnosed intraductal carcinoma of the prostate with grade group 1 cancer will be associated with similar features on prostatectomy, whereas 80% will again represent undersampled or unsampled high-grade prostate cancer. Morphologically, these two types are indistinguishable. Okay, now this is the microphotograph where you can see intraductal carcinoma of the prostate with cribriform lesions associated with high-grade prostate cancer, which is grade group 5. And on the right-hand side is our immunostain, which highlights a presence of basal cell around this intraductal component. As I mentioned, the intraductal carcinoma of the prostate, which is associated with high-grade features and bad prognostic features, will have overexpression of ERG, which is a nuclear marker. And on the right-hand side, you can see normal prostate glands, which do not show any upregulation of ERG. The cells that are highlighted on this microphotograph by ERG are the endothelial cells of the vessels associated with the normal prostate gland. And of course, they also show loss of P10 staining. And on molecular differences, we see loss of P53 and RB1 are present in the more commonly seen intraductal carcinoma of the prostate, which is rarely seen in high-grade PIN, and ERG mutations and ETS gene aberrations are seen in up to 75% of the regular, more common variety of intraductal carcinoma of the prostate, and seen much less in high-grade PIN. So this is an example of a precursor or in situ high-grade intraductal carcinoma of the prostate, cribriform pattern. Here you see there are these expansile glands and ducts with retention of basal cell layer. Each and every gland or acinus that you see has retention of basal cell layer. Now, as I mentioned before, if you have this finding on neonatal biopsies, you need to tell that intraductal carcinoma is present, and that up to 90% of these cases, when followed up, are actually do represent undersampled high-grade prostate cancer. Only 10% of these lesions are actually pure intraductal. And this is again an example of intraductal prostate cancer associated with grade group 1 prostate cancer. Again, only 20% of these actually represent intraductal with grade group 1 on prostatectomies, but majority of them, again, are associated with high-grade prostate cancers, which are not sampled in these biopsies. So intraductal carcinoma of the prostate, if it is isolated on the biopsy, it is not to be graded. And both GUPS and ISUP agree on this. And you can add a comment on the clinical significance of intraductal carcinoma of the prostate. Presence of intraductal carcinoma of the prostate is a contraindication for active surveillance even if it is seen as an isolated finding, or if it is seen in association with grade group 1 prostate cancer, it is again a contraindication for active surveillance, because majority of these cases, up to 80 to 90%, again represent undersampled high-grade prostate cancer. And germline testing should be considered in patients that have intraductal carcinoma of the prostate. Now we come to the a discussion to grade or not to grade intraductal carcinoma of the prostate when seen with concomitant prostate cancer. So the GUPS says it recommends not grading intraductal carcinoma of the prostate in presence with concomitant prostate cancer. And it recommends doing basal cell marker immunostains to differentiate intraductal carcinoma from prostate cancer if the results would change the highest Gleason score of the case. And it would not like to, and why does it say? Because they say they would not like to upgrade prostate cancer, especially in cases where precursor intraductal carcinoma of the prostate is associated with low-grade prostate cancer. For example, if you have intraductal associated with grade group 1, they say they don't want to combine the two and call grade group 1 prostate cancer to grade group 2 or grade group 3, depending on the percentage of intraductal that is present. However, ISUP recommends that we incorporate intraductal carcinoma into the grade group in the presence of concomitant prostate cancer. Hence, you do not need to do basal cell markers, immunostains. Why does ISUP recommend that? It says because currently the risk stratification models like NCCN, they do not incorporate intraductal carcinoma in their prediction. So if you include intraductal carcinoma into the grade group, that would at least partially address the prognostic impact of intraductal carcinoma of the prostate, which is currently missing in many stratification algorithms. Now, what does it mean? Let's take certain case scenarios. If you have Cribriform intraductal carcinoma of the prostate with grade group 1 invasive cancer, according to GUPS, you will not grade Cribriform intraductal, but will only grade the invasive cancer, and you will call it grade group 1 cancer. However, per ISUP, you will incorporate it into your grade group, and because it's cribriforming, you will either call it grade group 2 or grade group 3, depending what is the percentage of your cribriform lesion. Similarly, if you have grade group 2 prostate cancer with intraductal, per GUPS, you will not include intraductal and you will call it grade group 2. However, per ISUP, you will end up calling it either grade group 2 or grade group 3 cancer, depending on the percentage pattern 4 or how much cribriform lesion is present. Another scenario is if you have a cribriform intraductal majority associated with small focus of grade group 2 cancer, you will call it grade group 2 based on GUPS, because we will not take the intraductal carcinoma into our grading. However, per ISUP, because we include it in our grading, we would call it a grade group 3 prostate cancer. And the last scenario would be intraductal carcinoma with cometonecrosis and grade group 3 cancer. Because cometonecrosis is present, ISUP will call it a pattern 5, and we would give it a Gleason score of 9, 4 plus 5. Whereas GUPS will not include intraductal and will only so it will not upgrade it and call it grade group 3. So here is where the discrepancy is. But what is the magnitude of discrepancy? The magnitude is very less. There is very little difference when we see how common are these scenarios. These scenarios are extremely rare. Maybe up to 1 to 1.6% seen in prostate biopsies and no more than 1.6% seen in radical prostatectomies. And in discordant cases, grading intraductal carcinoma of the prostate usually will yield a higher grade group than not grading it, right? And the two grading system and grading recommendations yield little difference in terms of grade group assignments. And when the clinicians take the final grade group that comes and they put it in their risk stratification models, it gets even more diluted and it has lesser impact again. So no more than 2%, it's less than 2%. So it's more of an academic exercise. So whether to grade it or not. So if we have a precursor type intraductal carcinoma of the prostate, or isolated intraductal carcinoma of the prostate, the incidence is very less. It is only 1.7% on biopsies, and the incidence is even less on prostatectomies, which are seen. And only 10% of the biopsies which have isolated intraductal carcinoma of the prostate will actually represent isolated intraductal carcinoma of the prostate on prostatectomies. Majority of them will have undersampled high-grade group prostate cancer. And if we have intraductal carcinoma of the prostate with grade group 1 prostate cancer, only 2 to 3% of the biopsies show this phenomena, and only 1.4% of radical prostatectomies with intraductal carcinoma will have grade group 1 prostate cancer. Majority of these are associated with intraductal carcinoma associated with higher grade group prostate cancer, which is undersampled. So, 10 to 20% of our precursor type intraductal carcinoma will have no prostate cancer or only grade group 1 prostate cancer. But 80 to 90% will have undersampled grade group 2 or higher prostate cancer. So the grading is for pure isolated, do not grade it. And many pathologists also believe that if intraductal carcinoma of the prostate is associated with grade group 1 cancer, do not grade it. Do not combine the two. Call it, do not combine intraductal with invasive. Just grade the invasive separately. However, if you have usual intraductal carcinoma of the prostate, which is associated with grade group 2 or higher prostate cancers, you may include intraductal carcinoma of the prostate with the prostate cancer and combine the two and give the final grade group. Basal cell marker immunohistochemistry, yes, if you follow the GUPS, and if you want to distinguish precursor type, you need to have the immunostains. However, if you have grade group 2 or 5, grade group 2, 3, 4, 5 cancer associated with intraductal, it becomes optional, but it is not recommended that you do these immunomarkers. So with this, I will move on to case 3, which is of a prostate biopsy on a 64-year-old man who presented with hematuria, urinary obstruction, and mildly elevated PSA, and TURP was done. Again, you can see this is a TURP specimen because it's much bigger than a prostate biopsy. And what you can see here is a lesion which is very expansile, very busy. It is predominantly at this power. It is forming some tubules, maybe some cribriforming is there. And on high power, you can see there is some cribriforming. Cells are present back to back without any intervening stroma or fibrotic tissue in between them. And what draws our attention is the cells are tall columnar, and they are pseudostratified. Wherever we go, they are not cuboidal. And again, another view where you can see they are forming very thin, slender fibrovascular cores. And there are, again, small, tertiary, secondary papillae budding out of these foci. Again, one of the features, you have the cells arranged in fibrovascular cores, and on high power, you can see the cells are tall columnar with pseudostratification, and they are not cuboidal. They do not form small round glands. Again, very tall columnar. So We did immunohistochemical stains. This is P63 basal cell marker, which is absent in this lesion. And another marker which I should have shown you, I have not, is the prostate markers. You need to know. Prostate markers were positive in that, and this was a ductal adenocarcinoma of the prostate. So ductal adenocarcinoma of the prostate is characterized by tall columnar cells. Presence of the basal cell layer may be absent, or it can be present in a patchy manner. And a prostate ductal adenocarcinoma has different architectural patterns to it, and Cribriform pattern is one of them. It can be arranged in Cribriform pattern, but the Cribriform cells will be tall columnar pseudostratified. It can show papillary pattern, very commonly seen. Solid, single glands, and pin-like patterns are also seen in conjunction. Usually we have admixture of different patterns. And the range of cytological atypia can range from very bland to overtly malignant tumor cells. More commonly, we have admixture of acinar and ductal components, because a combination of acinar and ductal adenocarcinoma is more common than pure ductal adenocarcinoma. In fact, pure ductal adenocarcinoma is extremely rare. Less than 1% of prostate cancers have pure ductal histology, and these arise around the periurethral prostatic ducts around the verumontanum. These patients usually have normal digital rectal exam, because the lesion is present within the urethra, in and around the urethra. Hence, they present early. They can present with urinary obstructive symptoms or hematuria, and are commonly diagnosed on TURP specimens. If you do a prostate biopsies on the periphery, they may miss this lesion. And this is another example where you see the tumor cells. They are forming fibrovascular cores lined by tall columnar epithelium, and they are in fact growing within a benign gland or duct and expanding it. And this is the basal cell marker. You can see presence of basal cell layer. So prostate ductal adenocarcinoma also have a component of intraductal spread to them, similar to what we've seen in SNR cancer. This is another example of a patient who presented with hematuria and had a polypoid mass in the urethra. They did the urethral resection, and you see this mass is composed of these fibrovascular cores, and the cells are again tall columnar. This is high power view. You can see they look extremely bland, but they are tall columnar, pseudostratified, and they are positive for NKX 3.1, which is a prostate marker. And when we did PIN4, the MCR was expressed, but they had presence of a basal cell lining throughout the lesion. So these are what some pathologists believe a carcinoma in situ component, or the intraductal carcinoma of the prostate. If it's a progressive sequence from ductal carcinoma in situ, which involves the periurethral glands, to invasive ductal carcinoma that can superficially and then later on deeply infiltrate into the prostate gland. Now, if these lesions are caught early in development, they can actually be cured by small prostate biopsy, or TURP. This patient had a subsequent prostate biopsy which did not show any cancer. Of course, the standard biopsy would sample the peripheral zone where this lesion is not present. So it's not surprising that there was no cancer. So how do you distinguish ductal carcinoma from high-grade PIN? It is, again, the presence of tall columnar cells, which are very classic of ductal adenocarcinoma, the pseudostratification, and a presence of fibrovascular, the papillary structures with fibrovascular cores. High-grade PIN will have either flat, micropapillary, or tufted growth pattern. They do not have the fibrovascular cores. But ductal carcinoma will have a papillae lined with fibrovascular cores, again, which are lined by tall columnar cells. They can show, as I mentioned before, loose Cribriform pattern with large slit-like spaces, but these spaces are again lined by tall columnar cells. Now, on the left-hand side is high-grade pin with a micropapillary growth pattern and, of course, cytologic atypia, which all of these lesions will show. And on the right-hand side, we see Cribriform lesion. However, these are elongated slits, and the cells are tall columnar cells. And if we go around, we did have nice fibrovascular cores in this case as well. But yes, it does mimic intraductal carcinoma of the prostate. And again, on the left-hand side, you have higher power view of high-grade pin without micropapillae without fibrovascular cores, but ductal will have nice fibrovascular cores that are lined by tall columnar cells. And these are the basal cell markers present in high-grade pin, and the ductal will have can have a spotty presence of basal cell markers. They can either be completely negative, no basal cells present, or can have spotty. However, if they are growing within a benign duct, as I showed you, they will the basal cells will be highlighted of the benign duct. Now, ductal adenocarcinomas, as all of us know, have more aggressive course, and they frequently metastasize to penile and testicular parenchyma. Most of them are graded as 8, and these are different from pin-like adenocarcinomas. Now, pin-like adenocarcinomas was initially called pin-like ductal adenocarcinomas because they also had tall columnar epithelial cells. However, now we prefer to use the term pin-like adenocarcinoma and not to confuse it with ductal. Pin-like adenocarcinomas are characterized by tubule formation, which can be elongated tubules, and they are lined by tall columnar cells. Hence, they mimic prostate high-grade pin. Hence, the name pin-like ductal. They behave in a very nice manner, and they are graded as grade group 1, 6, 3+3. Pin-like adenocarcinomas can also show elongated lining of the epithelial cells. The cells can be low columnar to maybe cuboidal, and if you throw a pin-4 stain or a basal cell markers, will show absolute absence of basal cell layer. So how do we distinguish intraductal carcinoma from the ductal carcinoma? Now, intraductal carcinoma of the prostate usually has cuboidal epithelial cells compared to the ductal carcinoma, where the cells are tall, pseudostratified columnar. And both of them can have cribriform pattern. However, the cribriform pattern seen in intraductal carcinoma of the prostate will have round lumina, whereas a cribriform pattern will in the ductal carcinoma will have elongated slit-like lumina, and you will have a true papillary fronts close by very commonly. Whereas in intraductal carcinoma of the prostate, it will not have papillary structures with true fibrovascular cores. It will have only micropapillary tufts at the most. So moving on, we have case 4 of a 64-year-old man with elevated PSA. So prostate biopsies were done. Now here, this is the prostate biopsy. We see there is an expansile acinus or a duct. And within this, there is proliferation of epithelial cells. These epithelial cells are forming elongated cribriform structures, but they are occupying less than 50% of the glandular lumina. Here again, you can see an expansile acinus. Here, the proliferation is more than what we see in a typical high-grade pin. A high-grade pin typically will not show me these elongated bridging in between or forming these loose cribriform structures. So the architectural pattern is more than high-grade pin, but at the same time, this is not intraductal carcinoma of the prostate because these proliferations are less than 50% of the glandular lumina. And if we throw the basal, this is pin 4, these expansile glands and acini have presence of basal cell layer, although they are associated with invasive cancer as well, as you can see. Another microphotograph, if you look at this gland, it's got proliferation of epithelial cells, which is and they are forming loose cribriform structures here. And if we see on the right-hand side again, forming architectural complexity is there, which is typically more than what we see in high-grade pin, but it is not as the criteria for intraductal carcinoma of the prostate are there. So this is a lesion which is in between high-grade pin and intraductal carcinoma of the prostate, and we call it atypical intraductal proliferation. So how is atypical intraductal proliferation defined? It is defined as loose cribriform architecture where the luminal spaces account for more than 50% of the cellular mass, and it lacks the significant pleomorphism or necrosis, which is typical of intraductal carcinoma of the prostate. Atypical intraductal proliferations can have solid or dense cribriforming, but they will not span the entire lumen of the involved gland. They will only incompletely span the lumen. And the third definition of AIP is any lesion regardless of architecture, but if it has significant atypia, which is more than high-grade pin, but falls short of intraductal carcinoma of the prostate, you can call it AIP. So here are some of the examples. Most commonly, AIP that you will encounter in your practice is loose cribriforming of the glands with preservation of the basal cell layer. So loose cribriforming where the empty spaces are more than 50% of the luminal space of the gland characterizes intraductal proliferation. At times, you can have solid or dense cribriform also, but however, this will not span the entire lumen. It will only restrict to one side of the lumen, less than 50%. And the third criteria is nuclear pleomorphism. If the nuclear pleomorphism, even in a flat gland, with preservation of basal cells, is higher than what you typically see in high-grade pin, but falls short of intraductal carcinoma of the prostate, it is AIP. As I mentioned before, majority of the cases, up to 90%, will have loose cribriform architecture. Non-cribriform architecture may have a nuclear pleomorphism with tufted, flat, or micropapillary and tufted growth patterns. Usually you will have admixture of these patterns. Again, AIP, where you see a subtle tufting growth, and it is also involving, adjacent glands together, involving 2, 3, 4 large focus of glands is involved, and typically sometimes only partial involvement of the glands is there. Here you can see the atypical proliferation, but it's not expanding the entire gland. Part of the gland is not involved by it. So this is a paper that recently came out last month where the authors do tell that the diagnosis of AIP in prostate needle core biopsies is a marker of unsampled adverse pathology. And here you can again see the atypical proliferation in the form of these micropapillae, which is involving one gland and also involving the gland present adjacent to it. And then here only half of the gland is involved. And typically they also have a lot of eosinophilia associated with these lesions. So AIP can, again, multiple glands can be present per focus. They can cause expansion of the glands, and invasive prostate cancer is usually present in the proximity. This was an important, very interesting paper by Dr. Shah and colleagues where they studied AIP detected in prostate needle core biopsies, and they showed that AIP could be a marker of unsampled intraductal carcinoma of the prostate or other adverse pathological features. They had 6 biopsies which were initially diagnosed with AIP only, and they followed these up. And on follow-up, one of the biopsies had intraductal carcinoma of the prostate, and 4 had subsequently invasive prostate cancer, 2 of which were grade group 2 and 1 each was grade group 3, and grade group 1. Grade group 4 was, one of the cases was grade group 4 subsequently. And 3 of these cases had adverse pathological features. As you can see, 1 of them had intraductal carcinoma of the prostate, and 2 cases had grade group 3 or higher prostate cancer. And the biopsies, which were diagnosed with AIP when they had prostatectomies, they had 22 such cases. And out of these 22 cases, 59% showed grade group 2 prostate cancer, whereas grade group 3, grade group 4 with tertiary pattern 5, and grade group 5 cancers were also seen in a significant proportion of cases. So hence, AIP, when diagnosed on prostate needle biopsies, is commonly associated with adverse pathological features. Again, if we look at the molecular data, AIP is in between high-grade PIN and intraductal carcinoma of the prostate. As the lesions progress from high-grade prostate intraepithelial neoplasia to AIP to intraductal carcinoma of the prostate, loss of P10 and upregulation of ERG, the percentage also increases. So this is again a busy diagram where the differences of intraductal carcinoma of the prostate, AIP, and high-grade PIN are mentioned. Usually the cytological atypia is present in all, but the degree of cytological atypia varies. The maximum pleomorphism being seen in intraductal carcinoma of the prostate, and the pleomorphism seen in AIP is somewhat in between high-grade PIN and intraductal carcinoma of the prostate. And of course, a solid growth pattern, dense cribriform pattern are more frequently seen in intraductal, usually never present in AIP, the only exception being when only part of the gland is involved. Chlamydionecrosis never happens in high-grade PIN or AIP. When chlamydionecrosis is present with presence of basal cell, it is intraductal carcinoma of the prostate. A few words about Cribriform high-grade PIN. This is now controversial in existence, and most of the pathologists diagnose what they earlier would call Cribriform high-grade PIN as AIP now. So conclusions of frequent association of AIP with features of high-risk prostate cancers like cribriform glands and intraductal carcinoma of the prostate has been seen. So whenever AIP alone is diagnosed on prostate biopsies, it warrants a stat rebiopsy to rule out any unsampled high-grade prostate cancer or intraductal carcinoma of the prostate. AIP alone is not to be treated. And when AIP is present, it may give patients the option to opt out of active surveillance because it may be associated with adverse prognostic features. Okay, we move on to case 5. This is prostate biopsy in a 64-year-old man with elevated PSA level. Again, if you see here, this is cribriform, right? So now the question comes, will I do immunostains for basal cell markers or not? Yes, I will do it, because here my differential is intraductal carcinoma of the prostate or cribriform carcinoma of the prostate. So and this is the high power picture just to show you the cytology. And this is PIN 4, and here you can see there is absolute absence of basal cell markers. So this is cribriform cancer. In this picture, we would call it 8, 4 plus 4, so which is a mimicker of intraductal carcinoma of the prostate. And this is the last case that I will present of a prostate biopsy in a 65-year-old man. Here you can see a solid growth, which is expanding the ducts and acini of the prostate gland, and they show pleomorphism again, and this is PIN 4 that we did. However, as you can see, there is more brown staining than red staining. So this means that most likely the basal cell markers are being taken up by this proliferative lesion. In fact, this was urothelial cancer, which was colonizing the prostatic glands. And you can see PSA was absolutely absent in these in this cancer, whereas other markers like P63, high molecular weight cytokeratin, and GATA3 highlighted this tumor. So this was intraductal spread of urothelial cancer, which can happen, and it can mimic prostate cancer on needle core biopsy. It can also mimic intraductal carcinoma of the prostate. So again, we will have to use prostate-specific markers and urothelial-specific markers to distinguish these two. And I believe this is my last slide. And I will be happy to take some questions now.
While I'm unable to see too many questions, but if there aren't any, I have a quick question for you, Dr. Dhillon. Do you see a need to differentiate large cribriform from small cribriform?
Oh, based on the size right now, there is the literature does not really tell us if there is a difference between the prognostic, factors between large cribriform and small cribriform. Also, there is what is a large cribriform gland and what is a small cribriform gland. Different people have used different criteria. So we do not have a clear answer as of now.
Right. And do you in your routine practice use ERG and P10, IHC? How often do you use it?
No, we do not. In routine practice, we do not use P10 or ERG to distinguish, not really.
Right.
The only place where I've often used ERG is where, treated prostate cancer, it's metastasized, all of our prostate specific markers are negative.
Right.
Then I may use ERG as if positive, I may suggest it may represent prostate cancer, but in primary prostate biopsies, we do not routinely use ERG and P10.
Right. So in treated cases, have you ever had a situation where NKX3.1 and ERG are negative?
Absolutely.
Okay.
All prostate markers are negative. In fact, they start showing aberrant markers like CDX2
Right.
positivity. So that's a pitfall you need to know. So their clinical history becomes very important.
Right. So how would you sign out in those cases? I mean, you would just go by
We
morphology.
just sign it out as PD cancer and say that prostate cancer cannot be excluded.
Right.
Some people have suggested methylation profiles, but that is something new. I don't have much experience in that.
Right. Thank you. Anandi, do you see any questions?
No questions.
It just means it was so crystal clear. Your message came out very clear and the pictures were wonderful. So,
thank you.
And that's why probably we don't see too many questions. Does anybody have a comment to make? Anyone would like to say something to Dr. Dhillon or to Dr. Anandi, Dr. Bedi for conducting this wonderful series of lectures in the memory of Sambit, who was actually my junior from college, and I knew him from his undergraduate days. Bubbling little student. And I think what better way but to commemorate this great academician. It is unfortunate that he's not amidst us, but I'm sure wherever he is, he's enjoying the series of these lectures that are being organized in his memory. Anybody would like to say something? Or are we? Yeah, I think there aren't any questions.
I agree with you. He's one of a kind of an individual.
Absolutely.
Very helpful, excellent mentor I've seen.
Right.
Excellent academician.
And always
thank you for organizing it on his behalf, in his memory.
Yeah, right. So
he was so hyperactive. I mean, he was able to help us. He used to take our lectures almost 5 days a week. I don't know how, but he said, I will take it. And on different subjects.
Yes.
One day it was breast pathology, next day it was gynecology, third was molecular pathology, third day, fourth day it was renal pathology. It was like this, and amazing energy.
Absolutely.
I mean, his messages used to come at 2 in the night,
Right. I think all of
and
us are familiar with that. Yeah.
Yeah.
Yeah, it was, yeah, it's unfortunate that such a brilliant life should go away from our midst, but I think he's with us. And I think this is a wonderful way to keep it going. So I think we have the next meeting on 16th of July, Dr. Bedi.
yes.
So,
So then I have shared the link in the WhatsApp group,
right.
in the chat. You can just click on it right now and register. And yes,
And these will be available on YouTube, isn't it? For people
yes,
who
these
might
will
have
be
missed
available.
it.
The live chat is going on, and live recording is going on YouTube. It
Right.
will be available as soon as this lecture ends.
Right. And all the previous lectures are also available. So I think the word can pass around and people can actually access and keep learning from these lectures.
Yes,
Right. So thank
yes.
you then, Dr. Dhillon. Thank you very much. Thank you, Dr. Bedi. Thank you, Anandi, and all the others involved in organizing the series of lectures. Extremely grateful and thankful to all of you.
Thank you.
Thank you.
Thank you. Thank you
Bye-bye.
very much, ma'am. Yeah, thank you, Dr. Dhillon, for that lovely lecture. We've got lovely comment from our participants. Great lecture, excellent talk. Yeah. Yeah. So, yeah, with this, yeah, next talk, I'll just share the flyer. Yeah. Yeah, that's our next talk happening on the 16th of July. Dr. Andrea Costa will be talking on sex-cord stromal tumors of the testes.
Right.
Yes.
Okay,
You
then.
can register just right now. Just click on the message in the chat, or there's a QR code also on the screen. So we'll just wait for another 1 minute, and so that you can register, and then we will end the session.
Right. Oh,
In fact, a large number of people who delivered lecture, Jasreman was one of them who delivered guest lectures when Sambit was alive.
yes, in Bhubaneswar also, we got to hear,
Yes,
see you in Bhubaneswar for the meeting, the last meeting. So it was really
yes,
nice to have you, Dr. Dhillon. And I think each of these lectures is really refreshing and clears a lot of doubts, and people in daily practice actually could really refer to these lectures, since it's always available on YouTube as well. So,
yes.
okay, thank you very much then. Shall
Thank
we
you.
call it a
Yeah.
day? Yeah, thank you. Thank you, everyone.
Thank you.